all the three speakers, Akhil Smak, Dr. Sanjeevi, as well as Dr. Alok Kanungo. And ladies first, you can shoot your first question.
Thank you so much, sir. This was so fascinating, both the talks and the practical guidelines. And I was thinking of every point and how it can translate to the children that we are seeing today, all the latest science. So one thought that predominantly came into my mind with all the three presentations, the science of stages. So the siblings, all our children with type 1 diabetes and their siblings, is there something today practically as clinicians that we can do? Because every child has a glucometer, they are testing the sugars. So can the sibling be tested at a certain interval? Can their antibodies be screened? And how will it help? Can it help us at research level? Can we contribute as clinicians? And second, at a practical level, as a benefit to the sibling, is there something that can be done? Because that is a group which is in our control to some extent, who is coming to us.
Archana,
yes.
Me and Professor Sanjeevi and our group, yes, we did this family study of antibody markers and all the siblings of the family, and we found it's quite interesting. And few were also detected with antibody markers, even though they subsequently went into diabetes problem. So if antibody marker testing will be cheaper and easily available, this will become a routine practice. When a type 1 diabetes child is coming to us, we can always ask for siblings antibody markers, and that will help a lot in preventing or delaying the complications and managing the cases. And as Dr. Sanjeevi has told, the vaccine is coming, and in all those cases, the siblings can be given vaccines. And I would like to listen from Professor Lenmark on this.
It's a very good question. Thank you. And in the high-risk Scandinavian countries, 8% of the siblings have one or several autoantibodies at the time of the diagnosis of one of the first child. So it means that in many families, you will detect antibody positive siblings. And I think one of the important aspects is the education of the family. It's very difficult for a young family to have a type 1 diabetes child. But the other aspect is preventing ketoacidosis in the second child. I think it helps. The experience is that it helps to prepare the family for the possibility that there will be a second child.
Okay, I would like to know from you. Now we have got different scenario. We have got monozygotic twin, dizygotic twin, first degree relatives. What is the transmission in all these three? And what is the likelihood yield rate if I am checking all the monozygotic twins with type 1 or dizygotic or first degree relatives?
That's very interesting because the experience in Europe and in the United States is that if you look at individuals reaching 30 years of age, then the concordance for monozygotic twins is less than 30%. And it's still being debated whether you have followed the monozygotic twins long enough. So if you follow them for 60 years, maybe the concordance rate is increasing. So I think overall, though, the transmission rate in the monozygotic twins is low, much lower than in type 2. But it is, you're absolutely right, it is another high-risk group that if you have a monozygotic twin developing type 1 diabetes, it's really worth to follow the other twin.
And now we are on the antibodies. I would like to know from you, in a limited resource country or a setup whether it's Asia or Africa, it is not accessible, affordable, available, adaptable to get all the antibodies. I had a discussion with about a month back with my friend in Dr. Descharts as well as Lou Philipson. And we had a discussion about the antibodies. And they said, unless you do all the antibodies, doing one antibody, it really does not make much difference at all. I'm talking of a patient whom I have diagnosed. You have already shown clearly what about the zinc transporter rate, IA2 antibody, and also insulin autoantibody and GAD antibody. Now, in the, let us say, in the resource limited, I have got siblings. I start doing all the 4 antibodies and then follow them for many years. Or even in a patient who is newly detected, is it, suppose I have to choose 1 or 2 antibodies, which one I will do?
So I think with the new aspect of the etiology that enterovirus seems to trigger insulin autoantibody first, and it's in very young children, you know, below the age of 2 or below the age of 3. On the other hand, GAD autoantibodies is triggered, we believe, as I showed you from the TEDx study, that it's another enterovirus, probably adenovirus. And the age distribution is completely different. The GADA first comes at 2 to 3 years of age. It plateaus, it doesn't disappear. So I think in India, and I think it's a very important question about what's going on in other countries, such as Africa. I would say that with limited resources, GADA would be my choice. And in insulin autoantibodies also require the DR4-DQ8 haplotype, which is rare in India. It's of course present in Africa, south of Sahara. All HLA types are present from all over the world. But still, I think I would focus on GAD autoantibodies.
Prasanna Kumar, I just wanted to add one point here. This is about the affordability of doing the antibody test. There is a company called Diabatomics, which is a Seattle-based company, and they've got the IDS validation for that GAD antibody and IA2 antibody, which is based on test strips. And this is making it much easier in order to get a result at the clinic level, where the patient is the doctor is seeing the patient. So it is just a question of adoption of this test that will bring the prices down in order to make certain progress in terms of identifying whose autoantibody positivity, not only in children with diabetes, but also in adults with autoimmune diabetes. So the availability is one, the affordability is one, and some of the new technologies people are trying to come out with, the pricing is initially higher, but with increased adoption, I think the prices will come down.
Yes, Dr. Sanjeevi, I have been using it for the last 1 year. Point of care GAD antibody. I got it from Dr. P.V. Rao.
P.V. Rao.
Yeah. Can you hear me?
Yes.
Yeah. So P.V. Rao. But again, if you see, there are only a handful of institutions like mine who can do it, or I can do it free for 1,000 people. But look at a country where all over the country there are cases. They don't have the access to that because initial investment in the equipment is high. Then you have to have these things. And also if you have one patient in 6 months, it just doesn't work out also for that. So the kit also expires in 6 months. So that's why still, and they don't have IA2 antibody, insulin autoantibodies, and only GAD antibody is all what they have. So there are limitations for even this. It is not like a A1C which is available all over the country. And even if you do 1 or 2 antibodies, it may not help much in that. That's what I feel. Still, it's a long way before it is available all over the
And now, Prasanna Kumar, they have stopped the production of that antibody.
Yes.
And they're not giving the strips anymore. Otherwise, for 2,500 Indian rupees, Sanjeevi, it was bad. At least we could get so many autoantibodies, including what we may not need in all the patients, like TSH. All they were giving a lot of autoantibodies for a short amount of money. I just wanted to know what is the clinical difference between the GADA positive type 1 diabetes and the IAA positive type 2 diabetes, type 1 diabetes. Clinical differences, Professor Ledma?
Yes, it's a wonderful question. And there is emerging data from particularly Finland. But then we have to remember that Finland is in the lead of the highest risk, and they are very unique in their HLA distribution, etc. But let's take Finland as the example, because that's where the data is. And there is a recent study from the DIP group in Finland, which is a group of pediatricians, and I think you all know Mikael Knip and Rita Veula and that group. And when they examined more than 4,000 newly diagnosed type 1 diabetes patients on the severity of clinical onset, was there any acidosis, was there high level of hemoglobin A1C, etc., they could distinguish between a group having IAA first and the GADA first, that the IAA first was the more aggressive disease.
Okay.
And that was true even if the child had developed IAA first at 1 year of age and was diagnosed at 12. The severity at the clinical onset was different from a GADA patient with antibodies set at 6 years of age, for example. So you're absolutely right. I think we'll figure out a way with antibody typing and HLA typing, which trigger the patient had. And maybe in the future, as Professor Sanjeevi was alluding to, maybe we should start thinking about 2 different ways of treating these patients. It's a very good question.
One practical question to you and to Professor Sanjeevi. Sanjeevi and me wrote about it also. Does non-specific immunity elevation with BCG vaccine, is it going to be an answer? Is it one of the ways that in India we have less number of type 1 diabetes? BCG vaccination is done universally, and there is a certain period in certain countries when BCG vaccination was discontinued, and we found the prevalence of the disease increased. Any ideas on that?
Dr. Ashok, the BCG vaccination has been tried at a pediatric setting.
Yes.
Okay, but the clinical trial that is being conducted is in adult patients, adult in the sense that the inclusion criteria, they've had 21-year-old, 22-year-old individuals, and they are giving 2 doses of vaccine in that particular age group with 4 weeks apart. From a point of view of India, we just need to do the long-term study and see how the BCG vaccination is influencing the disease onset. So we together published a paper where we clearly showed those who are BCG vaccinated and develop type 1 diabetes have much lower GAD antibodies compared to those who are non-BCG vaccinated and develop type 1 diabetes, where 100% of the patients had autoantibodies. In terms of BCG as a prevention, I do not think it will be useful as a single approach, but maybe in combination with other approaches, as I was alluding to in one of the slides, combination of these intervention might be beneficial, but this combination also requires a highly powered long clinical study. Until we have those results, we can only look at the smaller study and come to some conclusion, but not enough to implement it in clinical practice.
I think I agree with Dr. Sanjeevi. And also all these previous studies shown BCG is not effective in preventing type 1 diabetes to that extent. What I would like to know is that the BCG we received 55 years back is not the same what we are going to use. What is the type of BCG vaccine which is more likely to be, even if it has something, let us say it will have, rather than the common garden variety of BCG vaccine?
Yeah, there are so many different BCG varieties available. And the one that they are using, which they call it the most immunogenic form of BCG, is the Danish strain. Okay. Yeah. Between the strains available in different parts of the world, one is the Tokyo strain or Glasgow strain or whatever, there is quite a bit of sequence difference that are seen between these strains, number one. Number two, considering the way the BCG was used to prevent tuberculosis in children, there was a paper in New England Journal of Medicine very recently, maybe recently in the last 2 years, where they have shown that intravenous BCG vaccination seems to prevent tuberculosis compared to subcutaneous vaccination. So the efficacy of BCG vaccination could also be dependent on the route of vaccination rather than what strain of BCG vaccination that you use. Maybe there is something there that we do not know, and we have been following the wrong dosage and the wrong route of administration. But again, we need to have larger studies, and this is something that we could do. When the BCG vaccination study for tuberculosis was done in India, it was a highly powered study. Millions of people were included in that particular study, and the statistical significance clearly showed BCG did not protect against tuberculosis, and the protection lasted only in those under the 5 years of age. So if you were to go back and do the same thing in an intravenous approach, maybe it will be different. From that point of view, the strain is different, the strain used is important, and also the route of administration becomes important. In the study that I quoted from Harvard Medical School, they're giving intramuscular BCG, whereas much of the approach that we are doing is subcutaneous BCG. So you might want to really question what is the best approach to give, but we don't have the answer right now.
Thank you. The last question, I've been all the authorities on the autoantibody here. Dr. Landmark, the father of autoantibodies in diabetes, you are a great worker in that field, taken over from Dr. Landmark and continuing it. Prasanna Kumar also has done in our country lock of zinc transporter. I wanted to know the zinc transporter 8 autoantibody. What does it denote? Anything particular about zinc transporter 8? Because no, IA2 we understand. GADA, Sanjeevi, your papers and the Professor Landmark's paper speak high of it. And then, of course, IA2. What about the zinc transporter? Does it mean anything special?
Okay, you can go first.
Yes, so it's very, very interesting because as you have seen, the zinc transporter 8 antibody is rarely, if ever, the first autoantibody. And one of the subtypes of the zinc transporter 8 antibodies, when it appears together with others, seems to accelerate progression to diabetes and affect beta cell function. So I think in clinical studies, and we just published one paper on a gluten-free diet randomized study, where we found that the zinc transporter 8 antibodies marked a not severe, but really marked stage 2 patients approaching stage 3 because of the zinc transporter 8 antibodies. And that was surprising to us. And the group I'll give you one more indication why we are excited about the zinc transporter 8 antibodies. And it is a transmembrane antibody, and Dr. Liping Yu in Denver has recently published a paper where he demonstrates specific antibodies to the plasma membrane of the beta cell. And that will be a distinct example of antibodies that bind to the surface of the beta cell and maybe affect the function that way. As you know, we often get that question, Sanjeevi and I, that if the antibodies do something themselves, and usually we say, well, we have no data to indicate that the antibodies themselves participate in the pathogenesis. But now we may have an example of the zinc T8 antibodies. So I think it's worth, if you have the opportunity, to look very carefully at these antibodies.
I think
they've made, yeah.
Dr. Ashok Das, one more point that you may want to remember about transporter antibodies is in a patient who have already been diagnosed with type 1 diabetes. You never know in an Indian setting whether they were diagnosed 1 year ago or 2 years ago. if you were to measure autoantibodies in such individuals, zinc transporter antibody would probably be the antibody that disappears first after they have developed type 1 diabetes. So GAD antibody stays much longer. So the timing of your testing is very important in order to identify which are all the antibodies that had been developed or what kind of autoimmunity they've had. At the time of diagnosis of type 1 diabetes, of course, that's a different matter. If you were to do it few years later, then the profile changes. This is something you may want to remember in a clinical setting.
Yeah, I think great answer. I think we have one champion amidst us, Dr. Sharda, and she has done a lot of work. She's our champion in type 1 diabetes. Sanjeevi knows it. She is the champion in the country. So I will ask her to, time permitting, with chairman's permission, to air some practical questions. She had dedicated her entire life to diabetes type 1 children. Archana?
Yes, sir. So I think a lot of practical questions, because they come up. First is starting from diagnosis itself, that in our clinical setup in our country, as Dr. Prasanna Kumar sir has always been guiding us, do we really need a lot of diagnostic tests? Can a child who comes to us with, say, ketosis, can be just taken as an enough criteria and be treated as type 1 diabetes for all practical purposes? Or are we missing it in our records if we do so?
Archana, that's a very important question.
Yes.
If ketoacidosis is there and the blood glucose is high, that says diabetes is there and ketone is there, means type 1 diabetes. Right. But once the child improves, we can go for C-peptide. Now, presently, classifying type 1 diabetes, classifying other groups of diabetes in young onset, C-peptide plays a major role. So that is cheaper and we can go for that. And if there is institutional support is available, antibody markers can always be tested.
So regarding C-peptide, sir, I think there's a lot of confusion. The right method, the right time, the right duration after onset of diabetes, fasting, or challenge with a glucose challenge. So what would you advise, sir? How do we go about it? Because there's no uniformity currently. I see reports which are done very early. Is that okay?
In fact, when we had a meeting last month, along with Des Shots as well as Sue Philipson, they said C-peptide is useless test. To the extent, we get so many of them, 1.6, 2.2, 3.2. And I presented these cases, just like that, baby type 2, GAD antibody is negative. He said, no, patient goes into long 6 months, 1 year of honeymoon phase, and then comes back with ketosis. So they said C-peptide, they have stopped doing because it cannot. It looks so simple for an undergraduate. Do C-peptide less than 0.6 type 1. Above this, I think practically it does not. Even with the best of the assays, whether it is point of care, whether you are doing a radioimmunoassay, I feel that doing C-peptide, okay, previously they said don't do unless blood sugar is controlled, then fasting blood sugar is 90 to 120, do it. Even then, it is not so useful to distinguish. I think your clinical judgment and other things, and because even after all the investigations, you find clinical judgment, and they said one thing, the progression follow-up of the patient will tell you very clearly, even if you don't do all antibody, even if you don't do C-peptide, over a period of time, you will know clearly what is type 1 and type 2. This is what my experience.
So, but for data purposes, I mean, because we are on a platform like this, for documentation purposes, suppose we are doing a registry, or we are contributing our data, do we need to have a specific criteria for diagnosis? Or can we say that
even if you do it is useless? Do you think you can have 2,500 patients, 50 centers? Do you think I can afford to GAD antibody, insulin autoantibody, AA2 antigen? Then I'll be spending maybe crores of rupees and just to publish one paper. What does it matter to me? Right? There are so many papers telling, some said that all the antibodies are possibly 10%, 20%. All sorts of data, and having 20, 30 patients in 20 centers has no meaning. National registry, when we don't have for type 1, what is the point in having antibodies with all that? I think that is neither practical, nor pragmatic, nor possible, nor affordable also. So that's why I don't think, or even HLA typing. Do you think in our country it is possible when HLA typing is different in north and south and east and west? Then so many papers we have seen 30 years from Mahuja to everybody. And each one has says, I have found this particular HLA type. I don't know, in my clinical practice, I don't find the utility at all, as long as I control diabetes. Coming to technology, what did USA say? 2012 to 18, 6 years data is published. The HbA1c was 7.6, now it is 8.6. Spending $20 billion and 23% more increase of pump and 53% increase of CGM. CGM pump alone is not going to see. The ideal control of 7 has never happened in DCCT also. So there is a huge gap between what is ideal, what is practical, what is possible. So that way everybody can sit and say, this is what I want ideal. I have seen 40 years ideal is just not possible, not practical.
I just have a question, practical question, personal. Maybe the last question time is getting up from you and Dr. Sanjeevi and Dr. Lenbach and give his opinion. What are the clinical differences? We know for certainty that we have a little more insulin reserve. What is the difference between the Indian type 1 diabetics and the type 1 diabetics that we see in Europe, say in the Nordic countries, which are absolutely insufficient? Is there a difference between the age of onset? What has been the global scenario, global presentation, the difference between the type 1 diabetics in this Southeast Asian countries and in the Nordic countries? Or Landmark can answer this question. Clinical differences.
Well,
yes,
Sanjeevi is of course the real expert, but I like to say and add to the fact that in Sweden that I know, and Finland that I know, and even Denmark, the practice in the clinic in pediatrics is you take care of these patients first and correct their metabolic disorder and get them controlled with insulin. And then if there is an indication in the clinic that the child is deviating, you may ask the question, is this a monogenic disease? Is it glucokinase mutation? And should this child really be treated with insulin? And, in a high-risk country like Sweden, we have 2% monogenic disease, where we avoid the fact that they will be treated. In glucokinase, they should not be treated. If it's HNF mutation, as you know, they should have glibenclamide or something else. So I think that's the approach that's even taken in Finland, Sweden, and Scandinavia. Look after the child first, and then you worry about the final classification. And then the difference between it's a very good question, because I think India is so interesting, because you have a contribution of DR3, DQ2, if you see on the HLA risk. And my prediction would be, and Sanjeevi can correct me if I'm wrong, the prediction would be that you overall have the milder form of type 1 diabetes. What do you think, Sanjeevi?
I agree. Not only that, in addition to DR3, the percentage of parasitic infections that the Indian children get infected with would alter the immune response in such a way that there will be a delay in the onset. The only thing that I would like to point out to Ashok Das's question is the way by which the type 1 diabetes presents to the clinic. In Sweden, the percentage of patients presenting with diabetic ketoacidosis is much, much smaller. If they present with diabetic ketoacidosis, that's an indication of failure of the healthcare system. Whereas in India, almost all type 1 diabetics present to the clinic with ketoacidosis and coma. So when they come to the hospital, they get admitted in the intensive care. That is when you make the diagnosis that this could be autoimmune type 1 diabetes. So the kind of presentation in India is so different, because the awareness is less, and awareness amongst the patients is less, so that they ignore the early symptoms. And the mother, of course, is in a denial mode. She would never say that, oh, my child has got type 1 diabetes. She will never accept it. So this is the clinical difference that you would see between patients presenting in Europe versus patients presenting in India. Okay, you agree from what Eva Ortquist and Bengt Persson had told us several times ago. The number of patients presenting in the pediatric clinic do not normally present with diabetic ketoacidosis. There are, even though there are few, but what are your thoughts? Okay.
No, you're absolutely right. I mean, in Sweden, I think at the time of presentation, we may have lowered pH in 30% of the patients, but ketoacidosis is a very rare event, usually in children below 5 years of age. And I think you're absolutely correct that in India, the children are kept at home much, much longer than they would be in Sweden or Finland or Denmark.
Thank you, Professor Okay. Thank you, Professor Landmark, Professor Sanjeevi, Archana, Dr. Prasanna Kumar, Dr. Das, Dr. Bhansali. This was a really very interesting session, and we could hear from the mouth of the horse or mouth of the lion. Professor Landmark is there, and what a wonderful session this is. And we added 30 minutes to this session extra to hear you and discuss this. So thank you very much. And thank you all the faculties and chairpersons for joining us in the National Update on Clinical Diabetes, that is NUCD 2022. This will be
Alok, you cannot forget your name. You were one of the contributors who were not selling. And I remember I first met Eke in the Gentofte laboratory, Professor Eke, you may not remember, in 1986 when you hosted that molecular biology workshop, and you had a big cake. You said we are trying to celebrate that. You know, I can't forget those 5 days in Gentofte and the big conference hosted by you globally. Thank you, Dr. Landmark, for generating.
Thank you.
I just one personal memory. When I reached Sweden for my PhD, and in Sanjeevi's department and Professor Oke's department, then first day I was sitting and doing some computer work. Somebody came in and tapped my back and told, "Carry on." And he was Professor Oke Landmark. I remember you, sir, from that day, and you are a great inspiration to all of us.
And Sanjeevi has also done extremely well.
He is with us. He is traveling different heights. Now he's the Vice Chancellor of Sri Satya Sai University. He's always a pride for us. And this, I assure you, type 1 diabetes work, both clinical and academic research work will continue in India, and they have really value. Unless we diagnose things, we do not do HLA, we do not do antibody markers, science will not progress. So we'll have to continue that, and Archana will lead this show. Thank you, sir.
Thank you, Alok. Thank you very much for the wonderful opportunity. Thank you.
Yeah, thank you.